Live is also starting. Very good afternoon to all of you. For today's session, as part of the Cuddles online neonatology initiative, we have a neonatal and pediatric super specialist with us. We have Dr. Pandu Chauhan. He's our pediatric consultant gastroenterologist. Dr. Pandu has trained at All India Institute of Medical Sciences, Delhi, where he did both his PG in pediatrics and he specialized in pediatric gastroenterology. He's skilled with pediatric gastroenterology related procedures such as endoscopy, colonoscopy, doing liver biopsies, and the analysis and interpretation of various pediatric gastroenterology related conditions such as chronic diarrhea, failure to thrive, malabsorption syndromes, and neonatal cholestasis, amongst various other issues. Today, he is going to talk to us about a very interesting neonatal condition that we often encounter, neonatal cholestasis. We all know the importance of early evaluation and diagnosis, particularly with some problems in neonatal cholestasis, which include hypothyroidism, extrahepatic biliary atresia, galactosemia, and urinary tract infections. These are treatable causes wherein missing early diagnosis can lead to irreversible sequelae. So we invite Dr. Pandu to enlighten us about neonatal cholestasis, what it means, how it is defined, and what are the different causes, what are the pathogenic factors, how to evaluate and interpret various diagnostic tests, and finally how to develop a management policy for newborns with cholestasis. Over to you, Dr. Pandu.
Thank you, ma'am. Let us discuss cholestasis. So, neonatal cholestasis is one of the acute followed by chronic condition in the neonatal, which can contribute to the 1/3 of the chronic liver disorders in the pediatric age group. Okay, so today's outline will be this definition of the cholestasis, epidemiology, pathophysiology, and etiological profile, and then approach to the diagnosis and management. Yes. Same thing, okay. So the word cholestasis is derived from the Greek word choli, means bile. So stasis means impairment of the bile flow. So definition of bile is accumulation of biliary substances in the liver due to defective bile formation or bile flow. So it is difficult to measure the bile flow or bile formation, and difficulty clinically as well as by the lab. So we use bilirubin, which is a constituent of bile, as a surrogate marker for the cholestasis. So it is diagnosed clinically as conjugated bilirubin more than 1 milligram per deciliter when the total bilirubin less than 5 milligram deciliter, or more than 20% of the total bilirubin when it's more than 5 milligram deciliter. In North American European Society of Pediatric Gastroenterology even warrant evaluation for the cholestasis when direct hyperbilirubinemia more than 1 milligram per deciliter, irrespective of the total bilirubin. So when it's looked at the epidemiology, exact estimates are not known in India. However, incidence is 1 in 2,500 in term infants in North American society, North American regions. So biliary atresia is the most common all over the world in different geographic regions, 1 in 6,000 from Asia to 1 in 12,000 in North America. In India, it contributes about 1/3 of the chronic liver disease in pediatric group. So let us look at the pathophysiology of bile flow as well as cholestasis, which helps us in understanding the cholestasis, understand and looking at the newer diagnosis, which can also help us in starting the newer therapies. Okay. So let us, this is anatomical determinants of the bile flow. This is schematic diagram of the hepatic lobule. Okay. This is hexagonal hepatocyte with hepatic lobule with central venule and 6 portal triad. Okay. Here the hepatic arterial flow and portal venous flow from the sinusoid towards the central venule, and bile duct flows away from the central venule to the portal triad region. If you magnify this, you can see here, these are the hepatocytes with bile canaliculi adjacent to the hepatocytes. This bile canaliculi is protected by the tight junction protein surrounded by it. Okay. So bile is secreted actively into the canaliculi. From canaliculi, bile flows into the canals of Herring's. From there into the bile ductules, and bile ductules open into the interlobal bile ducts in the portal triads. From this interlobal bile ducts unite with the segmental bile ducts. Segmental bile ducts form the lobar bile ducts, and left and right hepatic duct, lobar ducts form the common hepatic duct, which form the extrahepatic biliary system from there. So here it is important to know is, so any disturbance to the normal flow of the bile can cause cholestasis. So when you look at the canaliculi, whenever there is hepatitis can be the swelling of the hepatocytes, which can occlude the canaliculi and causes cholestasis. Okay. At the same time, whenever there is obstruction to the flow in biliary ductules due to the decreased secretion of the water or bicarbonate due to the CFTR gene, can also lead to the cholestasis, like in cystic fibrosis. At the same time, the paucity of intrahepatic bile ducts seen in the syndromic and non-syndromic causes of the vanishing bile duct syndromes can also lead to the cholestasis. So these are the different causes of the paucity of intrahepatic bile duct syndrome, which are syndromic as well as non-syndromic causes. Syndromic causes are Alagille, which is caused by JAG1 or NOTCH2 mutations, and trisomy 17, 18, and 21. Other causes are metabolic disorders, which lead to the chronic liver disease, can lead to the paucity of intrahepatic bile ducts, and infectious and some drugs can also cause vanishing bile duct syndrome, and also panhypopituitarism can cause vanishing bile duct syndrome. So other most common pediatric age group are graft versus host disease, chronic hepatic allograft rejection, sclerosing cholangitis, biliary atresia. In the end-stage liver disease can also cause paucity of intrahepatic bile ducts. Others are sarcoidosis. So now let's look at the extrahepatic biliary anatomy. So both left and right hepatic ducts form the common hepatic duct, with the union of the cystic duct form the common bile duct. So any obstruction to the extrahepatic biliary flow can lead to the extrahepatic biliary cholestasis. Okay, here it can be biliary atresia is the most common, followed by choledochal cyst, and CFTR related cholestasis can also cause intrahepatic as well as extrahepatic cholestasis, as well as in bile duct bile plug syndrome, and due to compression due to the any extrahepatic either mass or any tumor or bile duct perforation can lead to the extrahepatic cholestasis. Overall, when you look at the bile flow, so humans have normally 3 grams of bile pool, so of which 95% is old pool, and only daily 0.5 gram per day is synthesized daily newly. And most of the bile is 95% of the bile which is secreted into the intestine is reabsorbed from, which is active transport from the terminal ileum. Okay, and only 0.5 gram per day is excreted, which imparts yellow color to the stool. So that's why in cholestasis, in few conditions when extrahepatic cholestasis is there, get pale stools. Okay. So this is intrahepatic circulation. Along with this bile intrahepatic circulation, or biliary components are also absorbed. Similarly, bilirubin and bile acids. So let us look at the biochemical determinants of the bile flow. So bile is predominantly water, 95% water, only 3 to 5% of the weight is by solutes. Okay, among them bile acids is the most common, followed by cholesterol and phospholipids, and xenobiotics, electrolytes, and proteins make 1/3 of the solute load. Conjugated bilirubin is very small, however it is easy to detect clinically and easy to measure, so that we use it as a surrogate marker for the cholestasis. So this is the solutes of the bile. So 41% is by the bile acids. Next 1/3 is by the xenobiotics and electrolytes, and followed by the phospholipids and proteins and cholesterols. So bilirubin is the contributes by the least, which is only 1% of the solute load compared to the all other components. So when you look at the bile acids has the important and highest component of the bile solutes, and at the same time bile acids also have the highest cholinergic potential, which can influence the bile flow. So when you look at the bile flow in humans, it is either bile acid dependent or bile acid independent or cholangioside secretion. Okay, the bile acid independent and cholangioside secretion remains same, where bile acid dependent bile flow increases with the increase in the bile concentrations in the biliary canaliculi. So let us look at this graph. So here, look at the bile flow. Here the bile flow is static, okay, when it's come to the bile acid independent flow. So when it's come to the bile acid concentration, the more the bile acid concentration, the higher will be the flow. Okay, this is the reason why we start with all children with azodeoxycholic acid, which is a synthetic bile acid, in case of cholestasis. So the moment we increase the bile acid concentration, it increases the bile flow and decreases its toxicity. So bile acids, predominantly we have the primary and secondary bile acids. So among them, the cholic acid and choledeoxycholic acids are primary, and deoxycholic acid and lithocholics are secondary. All bile acids undergo conjugation in the hepatocyte and then actively secreted into the canaliculi with the help of transporter. So as we already discussed, the bile acids has most cholinergic potential. Any bile acid synthetic defect can lead to decreased bile flow and cholestasis. So these are the bile acid synthetic defects which can cause cholestasis. Congenital bile acid synthesis defect 1, 2, 3, 4, and others are bile acid conjugation defect and cerebrotendinous xanthomatosis. Okay. These are the enzymes, and among them the most common is congenital bile acid synthetic defect 1, which is synthesized with the gene is 3-beta-hydroxysteroid dehydrogenase, which is most common, clinically similarly to the progressive family intrahepatic cholestasis type 1. So other neonatal onset is cerebrotendinous xanthomatosis with neurological findings and diarrhea as well. Others have the hepatosplenomegaly, and type 4 present in the adult. So we have seen that anatomical and biochemical determinants. Now let us look at the molecular determinants of the bile. So here it is the hepatocytes, okay, with apical membrane and basolateral membrane. So bile is actively secreted into the canaliculi with the help of the transporters. So we have 5 important transporters in the canaliculi, which are the phospholipid flippase, which is denoted by the gene ATP8B1, and the another transporter is bile salt exporter pump. So the gene responsible ABCB11. So another transporter steroline. So gene is ABCG5, ABCG8. So it causes cytosterolemia. So another transporter phospholipid floppase, which secretes phospholipids into the canaliculi. So gene responsible is ABCB4, and MRP2 secretes actively conjugated bilirubin and other conjugates into the canaliculi. So defect of it leads to the Dubin-Johnson syndrome. Here all these transporter defects can lead to different phenotype, either progressive familial cholestasis or benign recurrent intrahepatic cholestasis. Each transporter defect can lead to the 2 different types of phenotype. Okay, these are PFIC 1, 2, 3 and Dubin-Johnson syndrome. So the CFTR mutation in the cholangiocytes can also lead to the cholestasis. The CFTR channel secretes chloride and bicarbonate into the canaliculi. Absence of it can lead to the oversaturation of the bile and stasis. Then look at some transporter at the basolateral membrane or sinusoidal membrane. There are exporters and importers. So importers are responsible for the import of the bile acids from the enterohepatic circulation, also bilirubin from the serum into the hepatocytes for the conjugations. Okay, exporters are whenever there are excessive bile acids in the hepatocytes and conjugated bilirubin, they get exported from the hepatocytes into the blood. So here, whenever there is cholestasis due to any transporter or due to any cause, the conjugated bilirubin and the bile acids are exported through this transporter into the sinusoidal and into the systemic circulation, which causes pruritus and clinical jaundice. So along with this molecular transporter, there are also other nuclear receptors which are involved in the bile synthesis and which augments the synthesis of these transporters. Among them, farneside X receptor is one of the important, which is stimulated by the bile acids, which increases the activity of bile salt exporter from MRP2, MDR3, and organic solute transporter alpha and beta. So deficiency of this can cause cholestasis, which is similar to the PFIC. Okay, so other even CAR and PXR and retinoic acid receptors can also cause cholestasis in humans. Okay, however, these are very rare in the clinical scenarios. Okay. So these are the different genetic cholestasis types. PFIC 1, 2, 3 were earlier well known. Now there are, due to the advent of the clinical genetics and the new diagnosis, we have discovered 5 new PFICs. Type 4 due to tight junction protein. So we have seen earlier in the anatomical determinants where the canalicula is surrounded by the tight junctions. So mutation of the tight junction can leakage of the bile acids can cause damage to the hepatocytes. PFIC type is due to the farneside X receptor we have seen earlier in the molecular determinants, and others are myosin 5B can lead to the PFIC6. Either this can present as only isolated cholestasis or cholestasis with intractable diarrhea. So type 7 is by ubiquitin serine protease 53. Type 8 by a KIF protein. So kinesin related family. Okay. So these are the genetic cholestasis with molecular determinant. So when you look at the overall etiological profile, other than this anatomical and genetic, we have the infectious metabolic causes as well. So let us look at the etiological profile in India from the two largest studies. So when you look at the most common cause, up to 35% is extrahepatic or obstructive causes, followed by hepatocellular infections is the most common, followed by metabolic diseases. So it is extrahepatic infection, followed by metabolic, followed by genetic causes. When you look at the Western data, similarly here the indeterminate, which is present in 31% in our population, is 26%. Around 25% is extrahepatic biliary atresia, followed by infection and metabolic and genetic causes. When you look at the metabolic causes, galactosemia is most common, followed by glycogen storage disease, and followed by other tyrosinemia and chromatosis, hemochromatosis, and Niemann-Pick are the storage disorders. When it's come to the infection, CME is the most common, followed by sepsis, and UTI contribute up to 1/3 of the acute neonatal cholestasis cases in infective causes. The rest are other task infections. So when it's come to the congenital CMV, is the only exception where you need histopathological documentation beyond 3 weeks of age. Before 3 weeks of age, you can document congenital CME with the help of urinary PCR. After that, you need documentation of histopathology to diagnose CME hepatitis. So CME hepatitis is one of the easily misdiagnosed and mostly and given medications, and which is the exact diagnosis missed due to the longer usage of these medication. So we miss the other diagnosis due to the the diagnosis of the CME based on serology. Okay, so it lead to the delay of the diagnosis of the underlying diagnosis. Okay, here we can see the giant cell hepatocytes with intranuclear inclusions, and immunostaining you can see the intranuclear oval eye stainings, which is cytopathic changes of the CME, which is confirmatory. So what are the clinical features of all cholestasis? We have seen the genetic, anatomic, and as well as the infectious causes. So most common percentage is prolonged neonatal jaundice. So any neonatal jaundice lasts more than 2 weeks need to be evaluated. Only exception is in exclusive breastfeed infants. We can wait for till 3 weeks of age. By it should be reducing in trend. Okay. Other are alcoholic stools, high colored urine, organomegaly, bleeding manifestation, failure to thrive, pruritus, and dysmorphic features with poor weight gain. And this is all children needs to be undergo liver function test beyond 2 weeks of age. So mean age of seeking therapeutic care is 4.5. This is data is all over the world. Mean age of presentation to the tertiary care is 3 months, even in the developed countries. So mean age diagnosis 60 days. So this need to be improved, and the diagnosis of extrahepatic cholestasis need to be diagnosed as early as possible. So how to approach the cholestasis? So in cholestasis approach, most important in the history of the jaundice and the history of the symptoms, followed by family history, and look at the consanguinity, neonatal cholestasis in the parents or siblings, and whether any inquire about any repeated fetal loss, you can see in the genetic cholestasis diseases. Okay, in prenatal history, inquire about the antenatal ultrasonography, maternal infection in case of TARCH infection, cholestasis of pregnancy. Sometimes PFIC type 3 can present first time in the pregnancy, and some mitochondrial disorders can also present first time in the pregnancy. So it gives clue that the baby can also have the similar diseases. Also inquire of the birth details, and if any eye drops history, also look for the previous investigations of the eye drops. For the neonatal infection, look for the source of the infection, and also look at the inquire regarding the stool and urine color, whether exclusive breastfeeding, or otherwise how this child is. It is irritable, otherwise healthy, lethargy. This is very important because extrahepatic biliary cases are otherwise healthy, because hepatocyte involvement is late in the course. So it gives a misconception to the parent that their child is normal. In examination, oral assessment of the general health, well baby or sick baby, then look for the growth and developmental assessment. Stool examination is very important. It helps in the early screening of the extrahepatic diseases, and look at the dysmorphic features. And systemic examination, look for the abdominal examination for organomegaly and the hypoplastic genitalia in case of hypopituitarism, panhypopituitarism. And cardiac examination, look for the murmur. So we can see the cardiac disease related with the TARCH infection, as well as with embryogenic disorder like Alagille syndrome, where peripheral pulmonary stenosis is seen. Other neurological, look for the alertness, tone, and skin rash, look for the pruritus can cause severe skin rash, and bile acids, increased bile acids in the blood can cause severe itching and skin rash. Followed with system examination, also look at the spine, where you can see butterfly vertebrae in case of Alagille, and posterior embrotaxon in eye, and also see the cataract in galactosemia and fructosemia, and look for the other optical changes in case of storage disorders and visual abnormalities. So after the examination, then also is very important to look at the stool color. So we can use stool color card to look at whether the stool is acholic or colic. So stool color card initially first developed by the Japan, followed by Taiwan and Britain. So they use the HSV method, and so which is different from the RGB method of color saturation. So here they use the hue saturation and value, and the saturation value more than 60 is normal and less than 60 is ecolic. This has sensitivities of around 100% in case when we viewed by the photocopy. Okay. So here in ecolic stool, the saturation is 19 to 47%. In normal stool, 70 to 67%. So what is the sensitivity of this stool color card? Sensitivity and specificity. So it has very good sensitivity and specificity. Sensitivity of around 90 to 93% and specificity of around 80 to 90%. This is the latest prospective study from India, from SGPGI. So where the 3 cohorts are followed. So here the sensitivity of the cholestasis by the residents is 93%, by the parents is 86%. Okay, and specificity is 90% by the residents and 84% by the parents. So compared to the, it has very good sensitivity, which is equivalent to the HIDA scan, which has a 98 sensitivity, and specificity is better than the even the radionuclide scan. So it can be utilized as a screening tool at your first visit or during the hospitalization or even at the time of discharge. NICU teams can adopt this stool color card and can give it to their parents, which helps in the community-based screening of the biliary atresia or cholestasis, extrahepatic cholestasis. So it was useful in the Taiwan. The mean duration of when it is distributed to the parents of the discharged parents, the mean in the community, the mean duration of diagnosis of biliary atresia is reduced by 5 days, and mean duration of the surgery is improved by 4 days. So it is definitely helpful in healthcare workers as well as for paramedics as well as for parents. So we can adapt this strategy to look at the early diagnosis and referral of the extrahepatic cholestasis. So after the examination, we'll be able to look at whether and differentiate whether it is extrahepatic or non-extrahepatic cholestasis. Okay. In extrahepatic, the onset is usually at first week of life. In intrahepatic, it is variable. Jaundice is more severe in case of extrahepatic. Stools are persistently pale in extrahepatic causes. It is intermittently pale or pigmented in case of hepatic. Activity is normal. This is important here because in extrahepatic causes, hepatocyte is initially not involved. So the otherwise activity and weight gain is normal. This gives a misconception to the parents where they think that their child is normal and going to improve. However, in case of intrahepatic, that hepatocytes are involved from the beginning. So there will be loss of appetite, poor feeding, failure to thrive will be present. They will come to the therapeutic care earlier. This is why we need other measures like stool color card to early pick up the extrahepatic cholestasis from the community, and even in the practices in the physician practices in the periphery. So when it's come to hepatomegaly, it is late and abnormal consistency hard in, or it can be early, more common. And there will be mild to moderate derangement or severe derangement case of intrahepatic. Operative cholangiogram is abnormal, definitely extrahepatic. So prototype here is biliary atresia and here is a CME infection or genetic cholestasis. So examination, it helps us in the identifying the extrahepatic, which can reduce the unnecessary investigations as well as reduce the diagnostic time. Let us look at the after examination. Now we able to know whether sick baby, well baby, or we can also have some clues of extrahepatic or intrahepatic cholestasis. Now let us proceed further according to the algorithm. So there is one algorithm approach. So different institutes have different algorithm, which is similar in almost. So this is the AIMS algorithm, so neonatology protocol. So after examination, we'll be able to see whether the child is well newborn or sick newborn. Okay, in case of well newborn, it is important to rule out the extrahepatic diseases. So which requires urgent surgery, which also helps in the further prognosis and natal liver survival. So in case of this is busy slide, you can so visibility is little poor, but you can see. So when there is well newborn with, you can see whether pale stool or pigmented stool. So with well newborn with pale stools, so urgently we have to rule out biliary atresia. So first go with ultrasound, followed by liver biopsy with or without HIDA scan. So whenever there is, so the better outcome with surgery are less than 60 days when you have sufficient, when you don't have time to prime the child and then perform the HIDA scan and wait for time. Can liver biopsy has very good specificity, sensitivity of 98% and specificity of 95%. You can go with liver biopsy and rule in or rule out biliary atresia and surgery. In case of, if ultrasound is suggestive of cyst, then look for suggestive of colorectal cyst and surgical. In case of pigmented stools with well newborn, look for the ultrasound, and GGT is important here. If GGT is normal or low, it suggests of genetic cholestasis. Okay, and it is high GGT, then it can be non-specific. Then go for liver biopsy to evaluate the further test. If liver biopsy is non-diagnostic, then go for the genetic studies, genetic test. So this algorithm helps us in reducing the time and also pathway to the early diagnosis. When it's come to the sick newborn, first you have to rule out whether child is in liver failure. Okay, so the liver signs of liver is coagulopathy, low albumin, hypoalbuminemia, hyperammonemia. So we have to evaluate for if there is acute liver failure, then manage accordingly, rule out neonatal hemochromatosis and herpes infection, CMV, and also look for the HLH and metabolic liver disease, which can present as like galactosemia, fructosemia, tyrosinemia can also present as acute liver failure. In case of absence of liver failure signs, then look for the infectious causes. So there's sepsis, urinary tract infection, followed by other infections, as well as the metabolic disorders like galactosemia, tyrosinemia, and herpes, CME, and HLH causes. So now after this, the approach, we now have to proceed for the investigations. So let us look at the detailed in about the investigations. So first line investigation, we have to hemogram with differentials, complete liver function, GGT and INR with blood sugars. Thyroid function test is one of the most common endocrine disorder of the cholestasis, followed by panhypopituitarism. Then look for the infectious causes and also urinary culture, microscopy, and urinary non-glucose reducing substance. This is also very easily performed test, but can detect the treatable disease like galactosemia and fructosemia. So non-glucose reducing substance can be done routinely. So it is cheaper and can detect other causes. Only in case of severe cholestasis, it can give positive reports. Ultrasound should be done always in the fasting period. This is very important. Again, the neonate should be at least fasting for 4 hours. Then ultrasound should be done again after 1 hour after the feeding. That need to be looked at again. Then look for the eye opthal evaluation in case of storage and other metabolic disorders. So GGT is one of the important biomarker which gives clue to the some cholestatic disorders. Low GGT or normal GTD can be seen in PFIC type 1 and 2, bile acid synthetic defects, panhypopituitarism, and parental nutrition associated. Markedly seen in biliary atresia, bile duct obstruction, paucity of interlobar bile ducts, and alpha-1 antitrypsin deficiency, cystic fibrosis, other causes of neonatal sclerosing cholangitis. And other hepatitis causes can also have elevated GGT. So after the initial investigations and examination, we can go for the further second line investigation according to the diagnosis suspicion. Okay, if it is metabolic disorder, do for the glucose, lactate, ammonia, and ketones, triglycerides and cholesterol in cases of glycogen storage disorders, gall-Tassay, urinary suction assistant in case of metabolic disorders like tyrosinemia, and urinary assistant should be sent in the plastic vial. So in case of cholestasis followed by acute liver failure, during the acute phase, you have to send the TMS and GCMS, which gives a metabolic picture during that time. Sweat chloride in case of CFTR, and in case of suspected bile acid synthetic defects, do serum bile acid levels after stopping ursodeoxycholic acid or at the the first visit only. Okay. So in case of hemochromatosis, serum ferritin transfer in saturation, or if needed, biopsy. So infections, we can PCR for infections and liver biopsy in case of CME hepatitis. So it's come to the imaging. So most important imaging in case of male children is ultrasound. Other imaging are HIDA, echocardiography, chest X-ray, dorsolateral spine in case of skeletal survey or intraoperative cholangiogram. So fasting ultrasound very important, though it's operator dependent. It has very good sensitivity and specificity. It has to be done in the fasting period, and at least 4 hours of fasting is required. So we should ask children or neonate parents to ask prior to 4 hours and skip one feed and do the ultrasound just before the second feed. Okay, and immediately after the ultrasound, ask mother to feed the child and do the ultrasound even after half an hour the feeding. So this helps in the getting the all findings in biliary atresia. So fasting period of 4 hours. So findings in the biliary atresia, triangular cord sign and gallbladder abnormalities. So sensitivity of the combine these two triangular cords and gallbladder abnormalities 95%. Okay. There can be pseudo gallbladder or ghost gallbladder, which is atretic gallbladder, abnormal contour of the gallbladder, and decreased contractility of the gallbladder. So this is very important. Lack of normal post-feed will be contraction. This is very important. So generally, there should be ejection fraction. We can say this should be more than 50% of the gallbladder component should be emptied. Okay, whenever it is, so normally it can be more than 35%. But if it's less than 35% of the gallbladder is contracted, then it is again pathological finding of biliary atresia. So that is why you have to do in the fasting period again. So look for the postprandial. So we should help in the advise parents, and we also follow up closely with the radiologist and get it done. This investigation, these are important. Other signs are enlarged right hepatic artery, which is more than 0.5 meter compared to the portal vein. Hepatic subcapsular blood flow, portal hepatis, and splenomegaly are other findings. So gallbladder ghost triad, you can see the small atretic gallbladder, abnormal contour, and decreased contractility. So this small gallbladder again, you can see the positive triangular cord sign. So anterior to the, you can see the cord sign here, triangular cord. So this is the fibrous tissue of the hepatic duct. So dilated hepatic artery here. So small gallbladder, no post-feed contraction. We have seen the small gallbladder here. Post-feed, it is similar, no contraction at all. So it is suggestive of biliary atresia. So biliary atresia, very important, the history, the stool and ultrasound can give very good clue. So other findings can be diagnosed well in the US ultrasonography is choledochal cyst. So in the first line also detects sludge, calculi and thickening or nodular or any mass lesion. Only limitation, you cannot delineate the entire biliary anatomy. In older children, you need other investigation to delineate the entire biliary anatomy. So ultrasonography, another very utilization is percutaneous cholangiogram. In cases of doubtful extrahepatic biliary atresia, where peripheral cholangiography can be done, cannot be done, you can simply do percutaneous cholangiogram. So here the dye is injected into the gallbladder under ultrasonic guidance, and then the course of the dye is watched under the fluoroscopy. Here you can see that dye is injected into the gallbladder. There is no flow into the hepatic flow, the flowing into the intestine. So this suggests of biliary atresia again. So after the injection of the contrast into the gallbladder, it should flow into the liver. If it is not flowing into the liver, then it suggests of biliary atresia. So perioperative cholangiogram is gold standard. So this can replace the perioperatic cholangiogram in most of the situations. However, very commonly not done in all setups. So another investigation is HIDA scan, helping only in confirming the biliary tract patency. So thus you can rule out. So however, it can be non-excretory in the other cases as well. So sensitivity is very nice, up to 98%, but specificity is very low. It can be non-excretory in bile duct paucity, idiopathic neonatal hepatitis, as well as parenteral nutrition. So this is important to note that. So before HIDA scan, priming with UDCA is needed for at least 5 days, 3 to 5 days, according to the different institute protocol. Some institute may ask even phenobarbital as well. However, there is no definitive benefits with the phenobarbital or UDCA. So after the HIDA scan, after the immediate injection, you can see the tracer is uptaken in the liver, followed by you can see the tracer is in the kidneys here. Again, here you can see some excreted in the biliary system here. Here you can see the secretion into the intestine, which is the normal. So which is absent in cases of biliary atresia. So when you compare the phenobarbital and ursodeoxycholic acid versus only ursodeoxycholic acid, there was no significant or statistical difference between the two. So you can do with only ursodeoxycholic acid challenging. We cannot need to waste time. We challenge it with phenobarbital in few centers. Okay. So HIDA scan, normally the radiotracer activity is found in the bile, in the intestines, and slow and non-excretory in case of the severe cholestasis and biliary atresia. MRCP has only in adult children in case of suspected choledochal cyst. It has very no role almost in case of biliary atresia. So another important investigation needed is the histopathology. Histopathologically, we can diagnose almost. So when it's look at the study, the most of up to more than 50% of the biliary tract cases can be diagnosed first time with the biopsy only. Others have been diagnosed with the help of other measures like HIDA scan, but it has very good sensitivity and specificity, as well as for the biopsy gives to rule out other etiological profiles as well. So it has good specificity in case of other etiological profile as well. So it is normal liver architecture and H&E staining. Here you can see the portal triad with bile duct and hepatic artery, and so bile duct and portal venule and hepatic artery. So this is central venule. So between the two is classified categorized into 3 zones. The zone 1, zone 2, zone 3. Zone 1 has highest oxygen and highest nutrient zone, where most of the metabolic reactions undertaken here, followed by zone 2, which is medium. Zone 3 has less oxygen, less nutrients. So most of the xenobiotics occurs in the zone 3. So whenever there is ischemia, first the necrosis occurs in the zone 3 because already oxygen is low zone, where you have the increase, further worsening of the hemodynamics can cause necrosis. It is called centrivenular necrosis in case of congestive hepatopathy or CHF. So this is a liver biopsy in EHBA. So you can see this is the trichome stain liver biopsy. So this is portal expansion with extensive periportal fibrosis with bile ductal proliferation with biliary plaques within the bile ducts. Okay, there is bile ductal proliferation with bile plugs within it, with extensive periportal fibrosis. You can see this blue color is fibrosis. So liver paraptic cholangiogram followed by liver biopsy is liver biopsy followed by paraptic cholangiogram is the gold standard for the neonatal cholestasis. In case of, so when there is decreased time period, so am I audible? Where is the team? 1 minute. I will start with here. Continue. Okay. So in the, we can see the few biopsy slides here. This is the expanded portal triad. So here you can see the, in the portal triad, this is a ductular proliferation with bile plugs within it. So it is H&E staining. So here trichome staining, you can see periportal fibrosis, extensive periportal fibrosis. So liver biopsy in case of PFIC, what are the findings? Here you can see the image here. There are rosetting of the hepatocytes. So there is a rosette formation. Okay, few giant hepatocytes. Here you can see that these are the canaliculi in between the hepatocytes. Between the two hepatocytes, there is canaliculi. There is canaliculi. There is bile plugs in the canaliculi. And when you look at the trichome staining, these are the portal triads, very minimal periportal fibrosis. Okay, and immunostaining with the BSCP and PFIC1, there is absence of transporters in the biliary canaliculi. So immunostaining can help in PFIC 1 and 2, and biopsy will definitely gives a clue and also rule out the biliary atresia and other causes. So this is the another cause, like you can say intrahepatic biliary atresia, or which is the also known as paucity of interlobular bile ducts. So here you can see the expanded portal triad with some inflammatory infiltrate, with some hepatic venule, hepatic artery, and there's absence of the bile duct in it. There is no bile duct in it. So when there's more than 60% of the portal triads doesn't show any bile ducts, it is diagnosed as paucity of interlobular bile ducts. So after the histopathology, we can diagnose the surgical causes. For few indeterminate cases, we can early proceed for the genetic evaluation, which can help us in the identifying the underlying diagnosis and further treatment. So to confirm the diagnosis, potentially decrease the need for invasive procedures, also early initiation of treatment, and identify the candidate for liver transplantation in the early, which also helps in the aggressive nutritional therapy, and followed by early transplant, which improve the post-transplant survival as well. When you look at the yield of the genetic studies, so there is almost 60% yield in indeterminate cases. Okay, so this study overall involved 125 patients, of whom 96 are hypocholic stools. So overall of them 50 patients underwent genetic testing. So after the evaluation, only 14% remained indeterminate after the genetic evaluation. Earlier, we have seen in the etiological profile up to 25 to 30% of the cases all over the world are indeterminate. However, when we involve genetic testing, it decreases up to 14% in different studies. Okay, this is the And in this study, the overall 125 patients, only 14 were indeterminates. All others have a diagnosis, either genetic, extrahepatic, or metabolic disease. So this is the usefulness of the genetic studies. Okay, these are the investigations. So examination followed by some blood investigation, followed by radiological, histopathological, and genetic studies. According to the algorithm, we can proceed step by step. So which can gives us the adequate diagnosis in the very less time, and also helps in the early treatment and further surgery and other conditions. So let us have some case scenarios. So this is 2-month child by presented to OPD with jaundice since to 2nd week of life and associated with high colored urine and pale stools, no stiff and abdominal distension, bleeding manifestation, otherwise gaining weight, and otherwise active child. On examination, hemodynamically active, icterus present, liver is palpable 4 cm, hard in consistency, spleen is 3 cm. Stools were pale on examination, and repeated examination for 3 consecutive days, stools are pale. Meanwhile, child evaluated has some anemia and followed by cholestasis bilirubin of 13 and moderate elevation of the liver enzymes and elevation of the ALP, alkaline phosphatase, and GGT. So albumin is 3.4. So this is a neonatal cholestasis with raised ALP and GGT with otherwise healthy child. Okay, so it can be the with hepatosplenomegaly, it can be the case of, so it can be the cholestasis with extrahepatic biliary, extrahepatic cholestasis. So the next investigation is the well child. So this is the well child with pale stools. So we need to rule out the biliary atresia immediately. So we did ultrasound. Ultrasound suggested of hepatomegaly. There was coarse echoduction, no IHBRD. Gallbladder is 17 mm in size with poor postprandial contractility. There was 3 mm, 4 mm cyst seen at the porta. With others are mild ascites, enlarged spleen. So what is the diagnosis with this? Sometimes this cyst is confused with choledochal cyst. However, it is not the choledochal cyst. Now let us look at the confirmation. As this child present to us with the 2 months, so already 60 days has been passed. We want early diagnosis and for the referral to the surgery for the Kasai portal enterostomy. So on biopsy, there is lobular distortion with canalicular cholestasis, portal expansion with bile ductal proliferation, and with periportal fibrosis. Portal lymphoplasmatic infiltration is also present. So this is suggestive of biopsy suggestive of biliary atresia. So however, there is the cyst at the type of porta, which is the cystic variant of biliary atresia, which is type 2A cystic variant. Also, in these cases, we should not wait for wasting because this child has other clues as well. You can see there is hard liver consistency. In choledochal cyst, that liver won't progress into this much chronicity. So that's why these are the clues. It suggests of it is very important that where clinical history and examination is very important, which you should interpret all other investigation with the presence of this clinical and examination findings. So the cystic variant of biliary atresia. Let us have a look at the biliary atresia. So this Kasai classification type 1 to type 3. So type 1 is only CBD is obliterated. When it's a type 2, type 2A, there is a cystic CBD variant, and type 2B, complete atretic, common hepatic duct, cystic, and CBD. In type 3, atresia discontinuity of the both right and left hepatic duct, which are at the level of porta hepatitis as well. Type 3 is most common, followed by type 1. So biliary atresia is the most common cause of extrahepatic and overall most common cause of cholestasis in neonates. So it can be associated with syndromic situs inversus polysplenia and cardiac anomalies, which is overall the non-syndromic cause is 90%, syndromic is only 10%. Stool card has very good sensitivity of 90% in different studies. We have already seen in the previous studies. And so treatment is Kasai portoenterostomy. So normalization of the bilirubin within 2 months has very good prognosis with long native liver survival. So Kasai portoenterostomy is done by creating a Roux-NY, which is around 40 to 50 centimeter of proximal bowel, and followed by distal side to end anastomosis of the proximal bowel to the distal bowel. The larger the ascending loop, the lesser will the cholangitis and complications. You can see the liver, it is cirrhotic and nodular liver during the portoenterostomy. The most common determinant of the survival and prognosis of the Kasai portoenterostomy is the age at the time of surgery. So you can see in the this graph here, you can see the survival native liver, and this is less than 45 days. This is after 45 days. You can see here there is significant difference, more than 12.51% at the age of 15 years. So when Kasai portoenterostomy done less than 45 days, it has good native liver survival. Similarly, when you look at the black line, which is more than 90 days, which has poor native liver survivals, they require early transplant, and failed Kasai can lead to the early transplant. Again, this is the outcome from the similar study. You can see here during the jaundice clearance, you can see very clearly here the more than 50% at and the initial 2 months of period, whereas it is low when the operated in the higher ages like 90 days and more than 90 days, the clearance is very low. So less than 20% achieve bile flow performed more than 90 to 120 days of life. So this is the only important determinant, the surgery at the age. That's why we have to diagnose early with the help of stool card, history, and the early liver biopsy. We can diagnose early. Other extrahepatic is choledochal cyst. So this can be 5 types of choledochal cyst, Rodini classification. So ultrasound can help and diagnose in most of the cases. In adults and children, we can take help of the MRCP. So other few metabolic conditions, galactosemia is easily treatable and reversible condition, which can present like sepsis even with acute liver failure or sick child. So when it's children, most of them present with E. coli sepsis with liver dysfunction, which is characteristic of galactosemia. Diagnosis by very simple urine non-glucose reducing substance followed by galt assay, and treatment is also elimination of the galactose from the diet. So child can start with and soya-based diet, which is isomil. So other treatable with after early diagnosis is metabolic tyrosine, which can present with cholestasis, or it can present with acute liver failure with severe coagulopathy, or it can present with chronic liver disease, or even the risk of hepatocellular malignancy as well. So this is due to the 4-hydroxyphenylpyruvate dehydrogenase deficiency. Early diagnosis can lead to the nitisinone supplements, or it can be the we can prevent the complications. The only liver transplant is the only curative therapy in children with already cirrhotic liver. Medication won't work, and child need to be work up for the liver transplant. So let's look at another case scenario. So a 3-month boy presented to OPD with jaundice for 15 days, associated with high colored urine and pigmented stools. So associated with severe itching, causing decreased sleep and irritability, no sharp abdominal distension, bleeding manifestation. There is history of poor weight gain also present in this. The child is hemodynamically stable, picture is present, liver is 5 centimeters, spleen 1 centimeter, and stools are pigmented stools. And evaluations, child had hyperbilirubinemia with a moderate elevation of liver enzymes and normal GGT and alkaline phosphatase with low hypoalbuminemia. So this is normal cholestasis with pigmented stools with normal GGT. So we know the causes of normal GGT. The child should be evaluated for the same. So we should always, whenever there is normal GGT, we have to confirm it twice. 1 or 2 reports are needed for the same thing, and also look for the clinical spectrum and the clinical features. And so in this child, there is the well child with pigmented stools. So let's look at the ultrasound abdomen and GGT. We have already seen normal GGT. So gallbladder, coarse ecotexture of the liver with gallbladder is 22 mm with good postprandial contractility, and splenomegaly is there. So in case of very sick child, we have to look for the other diagnosis as well, like in case of metabolic disorders as well. So in this child underwent liver biopsy with 12 portal tracts with its lobular disarray, hepatocyte resorting is there with few giant hepatocytes, mild portal inflammatory infiltrate, and interlobular bile ducts are seen normally. So this child was suspected because normal GGT and otherwise clinical spectrum, clinical features suggestive of intrahepatic cholestasis. Further added for the immunostaining of PFIC, which is negative. So here the PFIC one immunostaining is not present. You can say it is positive. So it is confirmative. So in case of PFIC 1 and 2 can confirm the diagnosis in liver biopsy with the help of immunostaining. So these are the most well-known the progressive family intrahepatic cholestasis. 1 and 2 present with the low GGT variant. 1 can have other extrahepatic manifestation like diarrhea and pneumonia. It can rapidly progress to the CLD as well. 2 have giant cell hepatitis, and you can, so 1 and 2 can progress to the chronic liver disease. They may require intrahepatic partial intrabiliary partial intestinal biliary diversion. PFIC 3 can present from childhood to adulthood with chronic liver disease. It is high GGT PFIC. Which come to the management. So any cholestasis needs adequate growth assessment and nutritional assessment, and needs aggressive enteral nutrition. Energy intake should be more than 125% of the required dietary allowance. Protein intake should be 2 to 3 gram per kg, except in liver failure, you can restrict it to 1 to 1.5 gram per kg per day. In breastfeed infants, you can add MCT-IL in 2 to 4 divided doses. Liver transplant outcomes directly related to the nutritional status. So this is very important, and we should also start the children on ADEK supplements and calcium and zinc. So other supportive therapy, the children should be vaccinated fully to prevent the further damage to the secondary infections. In case of pruritus, you can increase the UDCA dose to 30 mg per kg per day. You can add rifampicin, phenobarbital if not responding to the ursodeoxycholic acid. So after the evaluation, we can have the specific therapy according to the etiology. In case of infection, you can get antibiotic or antiviral. For galactosemia, galactose-free diet. Tyrosine type 1 can be started if child presented early, and NTBC. If child is in cirrhotic, then you have to go for the liver transplant. In case of hereditary fructose intolerance, fructose-free diet. Hypothyroidism can be thyroid replacement. Cystic fibrosis, pancreatic enzyme replacement. Hypopituitarism can be all other hormone replacement. In case of bile acid synthetic defect, then ursodeoxycholic supplementation. And biliary atresia in the early can go hepatopoietic enterostomy. In case of later or more than 120 days, you can directly go for liver transplant. So other surgical causes. So overall, it's come to the take-home message. Early detection of the extrahepatic cholestasis is very important, because the age of the surgery is the only determinant which can determine the native liver survival and prognosis. So we can use stool color card as a good screening tool for both for parents at the community level, or as well as for the paramedics in the hospital as well. Kasai potents before 60 days has very good prognosis and native liver survival. Galactosemia to be ruled out in sick kids, which is easily reversible and treatable condition. nutritional supplements and aggressive interventions is very important, which also influence the post-treatment survival. Genetic analysis is important in indeterminate cases, which can give us early diagnosis and further plan and prognosis of the conditions. Thank you for the listening. So, can you have any doubts post?